Hello, everyone. Welcome back to our next session of ease-based CRM on overcoming treatment inertia in CRM disease. I am Yihui Zhang from China National Center of Cardiovascular Disease Eye Hospital, and it is also my great honor to be joined by my co-chair, Professor Stefano Del Prato, the professor of endocrinology of Pisa, Italy, the pre-president of EASD, and the president of European Diabetes Forum. And I am also glad to introduce our four excellent presenters today. They are Professor Gianluigi Savaresi from Karolinska Institute in Sweden, presenting the cardiologist perspective, and Professor Mashuville from University of Maryland in the US, presenting the nephrologist perspective, and Professor Julia Meder from Medical University of Graz in Austria, presenting the diabetologist perspective, and Professor Jean Philippe Minaj from Jewel Production and Riviera Checkup in France, presenting the primary care physician perspective. After all of these presentations, we will conclude with a panel discussion and Q&A. So please be sure, stay tuned and ask our questions. So I'd now like to pass over to Professor Gianluigi Savaresi to our first presentation. So please, Professor Gianluigi.
Welcome to this session entitled Overcoming Treatment Inertia in CRM. I'm Dr. Gianluigi Savarese from the Department of Clinical Science and Education at Karolinska Institute and heart failure specialist at the Södersjukhuset Institute in Stockholm. And I will talk about the cardiologist perspective on the topic. This is the list of my disclosures. So we have very clear evidence from randomized controlled trials as summarized in this meta-analysis that quadruple therapy and use of GDMT reduce the risk of cardiovascular mortality or heart failure hospitalization. And this risk for quadruple therapy is very much reduced by around 70%. But we have also evidence from large registries. These are three study performed on 3 different countries that actually guidelines are not really well implemented. Therefore, also GDMT is very often not completely optimized in daily clinical practice, with actually many patients not receiving GDMT or receiving lower doses of medication. And another problem is that very often implementation takes time and patients stay at risk during the time needed for the optimization of GDMT. We try to understand from physicians, actually in a survey, around 400 physicians in Europe, which are the reasons behind the limited use of GDMT in daily clinical practice. First of all, physicians replied by saying that GDMT, meaning quadruple therapy, is very unlikely achieved in many patients. As you can see here, more than 90% of patients of physicians were actually reporting that they don't think quadruple therapy will be achieved in most patients. And they were reporting as key barriers to the implementation of GDMT, hypotension, worsening renal function, hyperkalemia, and patients' adherence. Very often, these are tolerability issues which might limit GDMT implementation in clinical practice, but there is also very often overperception, as we can see in this slide, where actually, for example, if we mention hyperkalemia, physicians might react by reducing use of GDMT impacting potassium homeostasis, even if potassium levels are only above 5, and they may react immediately by withdrawing or reducing the doses of RASI and MRA without considering other options. So how to try to optimize GDMT in our patients while considering all these aspects? A very good approach, which has been recommended by the Heart Failure Association of the ESC some years ago, is to try to target patient profile and therefore prioritize treatment based on very few characteristics, which are very easily retrievable, and they are blood pressure, renal function, potassium levels, and heart rate. Based on these few parameters, we can actually tailor therapy based on patient profile. One major barrier to the implementation of GDMT was hypotension, as we observed in our survey. So in this kind of patients, which kind of medication could we use? First of all, MRA is a very good option. As you see in this analysis from the emphasis, the impact of MRA on blood pressure in patients with low blood pressure at the baseline is very, very small. And indeed, over the time, you even see that blood pressure increases. This is, of course, due to the improvement of heart function, but also it says that the impact on blood pressure at the baseline is very, very small. It's similar results for SGLT2 inhibitors, whether blood pressure is low at the baseline, the decrease in blood pressure at initiation of medication is also low. And it might happen that we cannot up-titrate beta blockers in daily clinical practice in order to achieve the heart rate target that we wish, because blood pressure is low. But we should not really forget, as shown in the SHIFT trial, that ivabradine actually reduce heart rate without affecting blood pressure, and it led in this clinical trial to an improvement of mortality morbidity by 20%. Another treatment to be considered in patients with hypotension, whether they have also worsening heart failure, is of course vericiguat. Vericiguat has been shown not to impact blood pressure, and if it does so, it does very little in only in older patients. Patients with CRM, of course, have CKD, and in patients with CKD and heart failure, of course, it's also important to prioritize those treatments which are pillars and foundational therapy for both conditions. And two key of these medications are RASI and SGLT2 inhibitors. We should not forget that in randomized controlled trials, ARNI have been shown to impact eGFR over time less than ACE inhibitor, and therefore they may be prioritized in patients with CKD and heart failure. We should neither forget that vericiguat had no impact on renal function in the Victoria trial, therefore another treatment which might be prioritized in this treatment. Another key barrier to the implementation of GDMT is intended to be by our physician hyperkalemia. And let's see which medication might be prioritized in these patients. So first of all, we might consider, again, ARNI in randomized controlled trials. It was shown that ARNI as compared to enalapril impacted less potassium homeostasis. It was even working as an enabler for MRA. And in SGLT2 inhibitors trial, it has been shown that patients assigned to the SGLT2 inhibitors arm were less likely to discontinue MRA. This might be due to the lower risk of hyperkalemia in patients receiving SGLT2 inhibitors. And in the Victoria trial, it was shown that there was no impact on vericiguat on potassium levels. And therefore, these are three treatments which might be prioritized in these patients. We should not forget that actually the new K binders are actually recommended to be used in order to achieve maximal tolerated GDMT, whether potassium levels rise over 5 in order to foster further therapy optimization. And another barrier which very often affects the implementation of GDMT is related to our healthcare system, so structural problem in our healthcare system. Whether we can structure properly follow-up in our patients, actually this leads to better use of GDMT, as shown in the left in the study where patients refer to the heart failure nurse-led clinic, and better use of ACE inhibitors in the arm and beta blockers. And on the right, you can see that patients who were referred to cardiology rather than to primary care actually were more likely to receive optimal medical treatment, and this really suggests that whether patients are not optimized in terms of GDMT, they should not be referred back to primary care. Another problem which affects our care system is often to have not dedicated personnel for heart failure. In this study in Stockholm, we showed that whether we implemented personnel working on heart failure in our hospital, this led to an increase in GDMT use and a reduction in heart failure hospitalization over 4 years. So implementing the expertise on heart failure in our hospitals is really key for achieving better GDMT use. And then it's very important to also structure our healthcare system in order to achieve an accelerated GDMT implementation, both in hospital and meaning in inpatients, but also in outpatients. On the left, you see the team heart failure study where patients were actually assigned to an arm where they were actually seen in an implementation clinic where nurses, pharmacists, and MD supported by telemedicine were implemented in few weeks GDMT used, and these patients were compared to patients assigned to usual care. You can see that there was a huge difference in use of GDMT by only 3 months. And let's not forget that in strong HF and early initiation before discharge of the 3 pillars at that time, not 4 because SGLT2 inhibitors were not available, and an early visit after the discharge led to a much higher use of GDMT in patients assigned to the treatment arm as compared to usual care, and this translated in lower risk of all-cause mortality, hospitalization, and better quality of life. Another tool which might be used for implementing GDMT is to integrate alerts in our charts, as shown in these very interesting randomized controlled trials, whether there were alerts, whether patients were not receiving GDMT, and this was not supposed to happen based on blood pressure, labs, ejection fraction, and so on. Actually, whether physicians saw alerts, this led to better implementation of GDMT over time. And in the EPIC heart failure trials, it was shown that whether we increase the awareness of patients for their condition by sending them material regarding readings regarding how they should be treated before seeing the physician, actually the patients will trigger the physician to prescribe the best of care. And in this trial, indeed, it was observed that patients receiving instruction about GDMT before actually seeing the doctor receive better GDMT as compared to the usual care. We should not forget that polypharmacy and adherence are another obstacle to the implementation of GDMT. In the guided trial, it was shown that patients on polypharmacy, which we really very often observe in patients with CRM, were less likely to receive GDMT for heart failure. And I would really invite you to read this this new position paper from the Heart Failure Association of the ESC, where we provide recommendation on how to handle polypharmacy in the setting of GDMT by medication reconciliation, by increasing the awareness of drug-to-drug interaction, fostering the concept of deprescribing, and so on. We should not also forget that electronic health record and registries might really help to recapture to our hospital those patients who are not on optimal medical treatment and they are lost to the follow-up. In the Swedish Heart Failure Registry, actually we screen for need of GDMT implementation, where we identify patients who do not receive GDMT, although they have good blood pressure, good renal function, and no contraindication to medication. We call them to our hospital and we foster implementation through the heart failure nurse-led clinic. This is to say that there are many obstacle that might actually barriers that might foster clinical inertia in our daily clinical practice, poor tolerability for some extent, polypharmacy, patient adherence, physicians inertia, physician unawareness regarding specific condition, and missed identification of patients. All these factors may be related to clinical inertia and limited GDMT implementation. But by improving the flow of patient through different departments, having better communication between cardiologist, nephrologist, diabetologist, and all the different figures involved in the treatment of these patients with multi-condition and involving also pharmacists and nurses might really lead to better use of GDMT and therefore better outcome in our patients. Thanks so much for your attention.